Hello. Thank you for asking me to speak at this year's conference. It's always a pleasure to speak to you. I'm Drew Provan, a haematologist at the Royal London Hospital. And I'm going to be talking to you today about controversial topics in ITP. So let me now share my screen with you. So there are so many controversial topics in ITP, but I've chosen things that I think patients discuss and are worried about. These are my disclosures. So I'm going to talk a little bit about the diagnosis of ITP, the quality of life, a very, very important issue for patients, COVID-19 and what it's done in terms of our management of ITP, how it's forced us to change the way we manage this disease, new guidelines, very briefly. I'll look at the old treatments and of course the new treatments, and I'll talk about how we've managed ITP during the pandemic. And then I'll try and suggest to you how we might manage ITP as we come out of the pandemic and what the future might look like. So the diagnosis of ITP is frustrating, I mean, to say the least. We have new guidelines, but I'm sad to say there is still no diagnostic test for ITP. We cannot diagnose this positively. We still have to exclude all the other causes of a low platelet count. And if we draw a blank and we find nothing abnormal except the low platelet count, then we say it's ITP. So it remains a diagnosis of exclusion. And this is very frustrating for patients because there are not many diseases in medicine where it is a diagnosis of exclusion. Normally you have a test or an X-ray or a scan or something which then confirms the presence of a disease, but we don't have that. And I'm not sure we ever will have that. And that's a whole different discussion. But all I can say now is there's still no diagnostic test, despite state-of-the-art guidelines having been published. Now, quality of life is the main and the principal factor for patients. It's what they worry about most, how they feel, how they can work, how they can do things, how they can live a normal life. And we have not really addressed this properly for a long, long time. We kind of suspected that patients were not happy with the diagnosis and the treatment, but it wasn't until the IWISH study was conducted by Novartis, where 1,500 patients were interviewed in 13 countries, along with 500 physicians, to see how they aligned in their thoughts about the disease and the diagnosis and the treatment and the impact on quality of life. So we know that patients are not happy with some of their doctors. They're not happy with the diagnosis. It takes too long. People don't know what it is. It's still a diagnosis of exclusion. People are not happy with some of the treatments that we use. We know that. We've known that for a long time, but now we have it in black and white. People are uncertain about the future. What will happen? Will ITP go away? Will it get worse? What about platelet counts? They go up and they go down. Should we worry about platelet counts that change a lot? And then many patients have fatigue, extreme tiredness related to their ITP that we don't fully understand. And we don't ask patients enough about fatigue when we see them in clinic. Depression, common in ITP, and inability to work, to study, to do the normal things. Now, we've tried in the new guidelines to bring in the IWISH findings, and we've tried to be more holistic in our approach to ITP, and you'll see that if you read the revised consensus document. Now, COVID, the biggest thing that's happened recently, of course, is COVID-19, the world pandemic, and it has been a complete disaster in terms of health, illness, death, financial cost to all countries. It's been a disaster. The whole thing's been a disaster. However, I would say it does come with a silver lining because there are positive spin-offs. It's made us stop in our tracks and rethink ITP management. We cannot manage ITP during a pandemic the way we would manage it normally, where there is no pandemic. COVID-19 infection is very serious if you're vulnerable, immune suppressed, comorbidities, elderly. So we've had to avoid immune suppression where we can. So we've reduced the use of our older treatments, the azathioprine, mycophenolate, rituximab, steroids, because of the COVID-19 infection. And we also have approval within the UK to use the TPO receptor agonists like eltrombopag and romiplostim very early in ITP way earlier than we're supposed to. And it's all because of the pandemic and the avoidance of immune suppression. Now, I mentioned we had the new guidelines. We've tried to make these as up to date as possible, but these were written before the pandemic. So having not factored in COVID-19, these guidelines, although they're nice, they don't really reflect modern practice as in over the last 2 years. Because we can't follow these guidelines because we have a serious viral illness. So these will need revising earlier than we would have planned, unfortunately. Now, we've known for quite a long time that the older treatments that we used before were not great. We knew that you were unhappy with the side effects and the fact that they were so unpredictable and whether they would work or not. And there has been a gradual decline in the use of the older therapies, even before the pandemic. But then the pandemic came, and then this really speeded up this move away from immune suppression. And I'll show you this old paper from years ago. I know it's old, but nonetheless, this group looked at their ITP patients to see that those who were becoming ill or who sadly died, what was this from? Was this bleeding? But actually in half the cases, it was due to the treatment causing infection, and infection causing either sickness or in some cases, sadly, death. So this is why the older treatments are not great. So let's look very briefly at the old treatments and the new treatments. So I'm going to go through very briefly steroids, IVIG, immune suppression, Rituximab, and splenectomy. Now, steroids we use still to this day because they're cheap, they work quickly within a day or two. But we use doses which are too high, and we use doses for too long. So a long course of steroids with a high dose makes patients very, very unhappy. So we know this from the IWISH study. Now, we already use lower doses of steroids in some circumstances. For example, someone who has ITP and has COVID-19 will use a much smaller dose. And to an extent, it still works. Excuse me. And in pregnancy, we use lower doses, and it works. So maybe we need to reduce the dose of steroids in all our patients. Maybe starting at 20 milligrams a day and then increase after a few days if it doesn't work, and then reduce the whole course over after 2 weeks. And the whole course should be really 6 weeks, no longer than 6 weeks for the whole course. Excuse me. So a low dose and a short course should be better. IVIG has been used since the 1980s, and it's fine. IVIG works quickly, and in certain circumstances where someone has a relapse or is newly presenting and has bleeding, we use IVIG. And it's useful in COVID-19 positive patients also, but the response is not sustained. It lasts for about 2 weeks, and then the platelet count drifts down again, but we're still using IVIG. Immune suppression. I'm not going to go through all these immunosuppressants. There are so many of them, and they're very variable in their efficacy. Some work well, some don't work so well. They have lots of toxicities. And in fact, the side effects really outweigh any benefits that you get. So we really don't like immune suppression, but we were using them up until the pandemic, but not so much now. Rituximab. Rituximab use was declining even before COVID-19. We worry about infection with Rituximab, of course, and then you have a virus like COVID-19. So the use of Rituximab has gone down dramatically. We've hardly used any Rituximab at our hospital in the last 2 years. I think one patient maybe, which is very low usage of Rituximab. Splenectomy, I don't want to discuss in detail. It does remove the site of destruction of platelets for many patients, and it can work. But again, you've got the infection risk as well. So I would say avoid splenectomy anyway. And the rate, even before the pandemic, was about 4% for ITP, very low, and even lower probably now in the pandemic. So how have we managed ITP during this world pandemic? Well, on the left, you'll see the old therapies. On the right, you'll see the new therapies. The old therapies on the left, the evidence base for the old drugs like mycophenolate is quite weak. They're slow to work, they predispose to infection, they can be harmful in pregnancy. The efficacy of those drugs is incredibly variable and definitely not advisable during a pandemic. On the right, the TPO receptor agonists, eltrombopag, romiplostim, now avatrombopag also. very strong evidence base. They're approved for ITP. They have full approval. They've been studied in ITP. There's no immune suppression, and the efficacy is very high and definitely preferable during a pandemic. So having said immune suppression is not good, did we stop all the immunosuppression during the pandemic? No, we did not stop it, because we thought that if we tell patients at home who are stable to stop their immunosuppression, then what will happen is they will relapse and they'll end up coming to the hospital, and then we'll have to start messing about with new treatments, and they'll have to keep visiting the hospital. You'll remember at the beginning of the pandemic that we tried to keep people out of hospital as much as possible, avoid visits to hospital. So we felt that if someone's stable, they should just stay on their immune suppression for the time being. But very, very few patients in the last 2 years have been started on an immune suppressant. Very few indeed, because for the reasons that I mentioned earlier. But what we have done is we've drastically increased the use of L-Trombopag and Romiplastim during the pandemic. We're quite used to using these drugs, but much later on in your disease. So we never used to use them at the beginning of ITP. We'd use other drugs, and then eventually we'd get to L-Trombopag or Romiplastim. But we know from various studies that if you use them very early, they're very effective. And it may be that if we use them early, then even more patients can be tapered off a TPO and be stable on no treatment. We see this around 20% or 30% anyway. Maybe it's higher if we use the drug earlier. And at the bottom of the slide, you'll see there that in Scotland at the moment, we have Avatrombopag, the third TPO receptor agonist, brand new. We don't have it in England just yet, but hopefully it will come fairly soon. So we have 3 TPO receptor agonists. And as I mentioned, NHS England allowed us to use, they gave us interim guidance that we could use TPO receptor agonists very early in the disease process for patients, which is great, because it means we can avoid immune suppression. So what would be the pros and the cons of using lots of L-Trombopag and Romiplastim? Well, on the positive side, these drugs work fairly quickly. The efficacy is incredibly high. About 9 in 10 patients will respond. You may see a treatment-free response where you come off the therapy and be on no treatment at all and be perfectly safe, or even with a normal platelet count. If you are on some kind of immunosuppression, this can usually be decreased or stopped. And the quality of life on a TPO is much better than any other drug. But on the negative side, the drugs, they're not instant. They don't work in a day. They take about a week. So you still need a little bit of something else to get the platelets up quickly. And some drugs need a little bit of training, like Romiplastim. It's an injection. You need to be trained how to inject, but that's not that difficult. And then there's the cost. They're expensive drugs. These are expensive, much more than the old drugs. So what is coming next after this pandemic? Should we go back to our old way of managing ITP, like we did in 2019? Steroids, immunosuppression, later a TPO receptor agonist? I think you're unlikely to want that, and I don't think we want that either. But then comes the reality is, can we afford the COVID type model? Can we afford to have everyone on TPO receptor agonists, patients who would ordinarily be on mycophenolate or azathioprine or something else, which is they're much, much cheaper? Can we afford to have everyone on a TPO? And this is going to vary country to country. Some countries, like India, for example, will never be able to afford this. The United States of America, of course, they can afford it. The UK, I don't know. So what do we have to offer? Well, there are now 4 drugs approved. That means having gone through clinical trials for ITP. Romiplastim, L-Trombopag, that's 10 years we've had those. Avatrombopag is the latest TPO receptor agonist. I mentioned is available in Scotland, but not in England just yet. And then fostamatinib also, which is Scotland. There are also drugs undergoing clinical trials for ITP. So the approved therapies to date TPO receptor agonists, 3 of them: romiplostim, eltrombopag, avatrombopag. Fostamatinib is a different type of drug, but it's approved for ITP. Nothing else is approved worldwide. On the right, in clinical development, these are in trials at the moment, some quite advanced stages of trials. We have drugs which interfere with the neonatal FC receptor, that's the anti-FcRn drugs, which look promising. We have Bruton tyrosine kinase, BTK inhibitors, again look promising. Drugs which inhibit the complement system, which may be involved in ITP, and there are other drugs also. So these are in development, these are not available just yet, but over the next few years they will be. So at the moment we have those on the left, the TPOs and fostamatinib. So what's likely to happen from now? Well, I think we will continue our high use of TPO receptor agonists. And I've put there, we'll use all 3 if necessary. So you may be started on romiplostim, and that may work or it may not. If it does not work, you could then try eltrombopag. If that doesn't work, you would then try avatrombopag. So you would work through whichever one you start with, you work through all 3 TPOs. And if all of those fail, then of course you have the approved drug fostamatinib as well. I think from now, I think we should all be aiming for steroid courses which are short, and that means 6 weeks or even less if possible. And the doses should be lower than the ones that we've been used to using. The standard dose of steroid, and even in the guideline, was 1 milligram per kilogram. So that means if you weigh 70 kilograms, you would receive 70 milligrams up front. I'm saying now this should be much lower, maybe 30 milligrams, 20 milligrams, and a short course, because that way you'll avoid all the, well, not all, but you'll avoid the majority of the complications of ITP, of steroids, like diabetes and weight gain and insomnia and all the other things that happen with steroids. For the time being, we're waiting for the new classes of therapy that I mentioned to be approved. The neonatal FC receptor blockers, the Bruton tyrosine kinase inhibitors, the complement inhibitors, and others. I think if the budgets allow, if the Department of Health and other people who pay the bills, I think if they let us, we will try to use the very little immune suppression, and instead we'll use TPO receptor agonists, which are more expensive, but if the budget allows, then that's what we will do. And the guidelines will clearly need to be updated fairly soon. Between the first consensus and the second was 10 years. Between the original ASH guideline and the revised ASH guideline was 10 years. We can't wait 10 years for the guidelines. We'll have to update them within the next year or so at the latest. So in summary, I think COVID has had a major impact on the world. It's been a complete disaster, but there are some positive benefits. I hope you will agree. It's forced us to rethink how we manage ITP. And it's very good news for you because it means you avoid the treatments which don't work very well and which give you lots of toxicity with hardly any benefit. And instead you get TPO receptor agonists, which are much better. So there was a gradual decline, as I said, in the use of immune suppression before COVID-19, but this has very much been accelerated because of the pandemic. We've had to change. We've had to change our practice. And I think that drugs like eltrombopag and romiplostim and avatrombopag are very likely to remain the dominant type of drug that we use. But other drugs are coming online, and over the next couple of years, we will have other new classes of therapy. And as I said, we need to update the guidelines very soon. So I will stop there and thank you for your attention.